Advocating for, and what I'm speaking about today, was doing more of a selective lymph node removal, taking into account the drainage of the lymphatics and the lymph nodes from the arm and preserving those whenever possible, and that reduces the lymphedema risk. And we've recently published on our experience in Montefiore showing that we have close to a zero lymphedema risk when we're mindful about that. The other thing that's really important is that we monitor patients for signs of lymphedema. So the traditional way where a patient is diagnosed with lymphedema would be sometime after they've had their breast cancer treatment. They say, "Hey doc, my arm is swollen." Well, that's not an early diagnosis of lymphedema. That's been sort of brewing for a long time. So now we have techniques to do what we call prospective surveillance to see if there's any change in the volume of the arm that we can detect it very, very early. So what we do is we do measurements. It's called bioimpedance spectroscopy. We use a particular platform which is called SOZO, which is a very simple thing for the patients to do. It's just like they're standing on a scale. And we do that prior to surgery so we know what their baseline arm measurements are like. And then when they come for follow-up visits, we check them from time to time to see if they're increasing their volume. They have no symptoms, but if the SOZO evaluation shows us that they're increasing the volume in their arm, we know that these patients may be on their way to developing clinical lymphedema. So we intervene for those patients by using a compression garment, like a support stocking on their arm. And what we found is that reverses the early changes of increased volume very quickly, so these patients don't go on to then experience lymphedema.